My name is Eric Whitman, as you said, and I work for University Urology Associates. And my talk is on prostate cancer. So as some of you probably already know, September is Prostate Cancer Awareness Month. And you guys are all doing your part to be more aware of prostate cancer today. Now these are the questions I want to try to answer during this talk. What is the prostate? A lot of people don't know. And what is prostate cancer? Included in that is how common is prostate cancer, what are the risk factors, how is it found, and we'll go into how prostate cancer is diagnosed. Can we turn the mic down a little bit? It's getting some feedback. You come in real quick. And what is the prognosis? That's what everybody really cares about when they're talking about cancer. Is you guys can still hear me in the back?
Oh, yeah.
Is what is the prognosis for prostate cancer? So hopefully we can answer all these questions today. Now, what is the prostate? The prostate is a gland that's found in males. There's my laser pointer. It sits below the urinary bladder, in front of the rectum. It grows normally with age. Over here on the right, that might look like, oh, that's bad cancer. That's actually just BPH, or enlarged prostate. Well, this is a normal prostate. And this is a normal process with aging. And BPH, or enlarged prostate, is not prostate cancer. The ads for the BPH medicines want you to think that to scare you and go get in their meds. But it turns out that overall the size of the prostate doesn't correlate with cancer, and it doesn't correlate with voiding symptoms either. It's a side note, but if you think that this is a donut and this is a donut hole you pee through, it's the size of the hole, not the size of the prostate, that matters for peeing. So I know guys with enormous prostates that pee fine, and guys with little tiny prostates that can't pee at all. So the size is actually not important, even though we call it an enlarged prostate for simplicity. So does anybody have questions about, and the prostate job, what is it? It's a gland that makes some of the fluid that your sperm swims in. So they help the sperm make that journey by helping to liquefy the fluid and get it through the mucus of the vagina. Is everybody clear on what the prostate is and what it does? Good. So now what is prostate cancer? We have to start by talking about what cancer is in general. If you guys come to a lot of these talks, you might have heard this general description of cancer before, but all the cells in our body are constantly growing, dividing, and then dying in an orderly way. And cancer occurs when they multiply faster than they die, and that results in a tumor. Now, not all tumors are cancer. There's benign tumors that aren't going to cause problems, and there's benign tumors that do cause problems. But what defines cancer is its ability to invade into tissues nearby or to spread to distant sites. Now, when we're talking about prostate cancer, we're primarily talking about adenocarcinoma. That's the type of cancer that grows there. There are some other types of cancer that grow there too, but they're rare, and we're not going to talk about them today because they're very rare. And you see the location again here in this cartoon: the bladder, the prostate, the rectum's here, and here's a picture of it up close with the bladder and the urethra coming through it. And this is the ejaculatory duct in the prostate, and this cartoon shows a nicely delineated tumor there. That's just a cartoon, of course. So how common is prostate cancer? Why is this important? So the latest estimates for 2015 say that there's going to be over 220,000 cases diagnosed this year. There's going to be over 27,000 deaths this year. It's the second leading cause of cancer death in men, only behind lung cancer. And there's currently 2.9 million U.S. men that are living with prostate cancer. So it's a big problem. And what are the risk factors? 6 out of 10 of the cases are in men aged 65 and older. It's rare before age 40. You see it, but it's it's one of those oddballs. The average age is 66. So age is the biggest risk factor, and then there's race. So African Americans, men of African ancestry, are much more likely to be diagnosed with prostate cancer, and it turns out it ends up being worse disease most of the time too. So they're twice as likely to die from prostate cancer. We've actually worked out some of the genes associated with that too. Now there's a family history is a factor like other cancers. If you have a father or a brother with prostate cancer, that doubles your chance of being diagnosed in your lifetime. And there are some genetic cancer syndromes, the BRCA1 BRCA2 you might have heard of with breast cancer, that can increase your risk of prostate cancer as well, and Lynch syndrome is another one. So how do we find prostate cancer? Some of the men in this room know what's going on here. So we usually find it by screening. We screen it with PSA, which is a blood test, and a digital rectal exam. Now, this is a true story. When I was a medical student and first heard the term digital rectal exam, I thought it was a computerized test. Oh, good, it's not analog anymore. But we all know what digit they're talking about. So we really find prostate cancer by symptoms today, but it does happen, and we'll talk about symptoms later. But this is how we usually find it. And I'm going to give you a brief history lesson. So some of you have probably heard about the controversy with PSA screening, and I'll go through it a little bit here. So PSA, what it is, it's called prostate-specific antigen, PSA for short. It's a normal enzyme that the prostate is supposed to produce. It helps the sperm along the journey, another thing that the prostate does. And there are different things that cause it to be elevated. Enlarged prostate. So as the prostate enlarges, the PSA rises too, and that's normal with age. So there's age normals for PSA. It's not that magic 4 number that you heard of. There's normal by age. A 20-year-old shouldn't be 4 or anywhere near there. Now, inflammation can cause the PSA to be wildly elevated, and that's another what we call false positive. So it's a positive test because it's elevated, but it's not from cancer. And prostate cancer is one of the things that can elevate your PSA, which is why we use it as a test. Now, there's the history part. Before PSA was approved by the FDA in 1986, the only way we found it was by exam. And when you find it on exam, it's generally worse disease because it's big enough to be felt. And lots of times, unfortunately, you'd find it from people coming with back pain and even paralysis from the tumor pushing on their spine, and it ended up being prostate cancer. So that's how people presented before PSA. But now we're diagnosing many more patients, and we're diagnosing much earlier. But the problem is we're probably diagnosing it too early, and we're probably finding cancers that aren't going to be significant in the long run. So we have something called the number needed to treat that we talk about when we're talking about whether to screen. So how many patients do you have to screen, and how many patients do you have to treat to save a life? And these numbers are too high for treatments that have some morbidity. So we have to screen 1,000 patients and treat 30 patients to save one life. So that means 29 out of those 30 patients aren't going to see a survival benefit to their treatment. So it's the second leading cause of cancer death in men, so we can't just stop screening when this is not the only tool. There's some emerging things, but this is the only one that's really available for screening. So we can't just stop doing it, but we have to be more selective about who we screen, who we biopsy, and who we treat. So we're treating less men that aren't going to see a benefit from it. Question, yes?
Exactly how much of an indicator is PSA?
How do you mean?
I'm kind of believing the indication could be all over the map.
Indication for getting a PSA?
In the sense that there's that number, that magic number of 4.
Mm-hmm.
And if you have an average of 0.8 or 0.6, and then it goes to a 2,
right,
it breaks a protocol, and then
right,
it might prompt a biopsy.
So
I'm confused on exactly
right,
what protocols do you have for when a biopsy is necessary.
What's normal, right?
Correct.
So what's normal? So we have age-dependent normals. So we have it all worked out what it should be at a certain age, and that's by size. And actually what I think is a more important factor is the velocity. So how fast it rises. So a really fast rise is almost always inflammation. Prostate cancer doesn't cause that. But a faster than normal rise is a patient that I'm going to find cancer on more often than not on the biopsy. So it's difficult to interpret PSA mainly because of the other things that elevate it. So you're trying to weed out who is probably more likely to be cancer and who is more likely to be from inflammation or just BPH. And it's difficult. I mean, we don't know the answers. We have to use all the tools available to us for the individual to figure out whether biopsy is the right thing to do or not.
What would commonly cause an elevation?
But
it's not cancerous.
Inflammation, BPH, those are the main things. There are even things like sexual activity can elevate your PSA briefly. But inflammation and BPH are the main things that cause an elevation.
Thank you.
So this is a big question, though, who to screen. We'll get to who to biopsy, too. I guess we kind of did that. That's a discussion that has to happen with the physician. There's way too many factors. That would be a whole hour talk about who to biopsy or not, and not necessarily an individual thing. But who to screen is another question we don't have the answer to, but I'll go through what's going on now. So there are multiple organizations that have screening recommendations. This is the one from the American Urologic Association. And they recommend no screening in men under 40. They recommend no screening in men 40 to 54 who have average risk, but that's when they recommend starting for men with risk factors like African heritage or family history. And for men 55 to 69, the group that's going to have the greatest benefit from screening, they have what they call a shared decision-making process. So what that means is that you have a discussion with your physician, and you decide together whether you want to screen based on all the individual factors of you and what we know about the data. And no screening over age 70, or if you have a life expectancy less than 10 years, because those patients are unlikely to see a benefit. Now, the American Cancer Society recommends risk-based counseling, a discussion at age 50 if there's no risk factors, and starting at 45 if there are risk factors. National Clinical Cancer Network has this complicated algorithm where they recommend starting a discussion at age 40 and taking a PSA. If it's less than 1 and stays less than 1, you check every 5 years and then yearly at 50. If it ever gets over 1 while you're still in your 40s, then screening yearly. Or if you have risk factors, and so you screen yearly at 40. Now this next recommendation is the one that's sort of sparked a lot of the controversy. So this is the organization that brought So this is the USPTF, stands for United States Preventive Task Force, and they gave screening with PSA a D recommendation. That means they recommend against routine screening. And what they found when they looked at all the data on prostate cancer, this is a massive search they do in multiple areas, that there was moderate or high certainty that the service has no net benefit or that the harms outweigh the risk. Now this is based on the number needed to treat of 30. If the treatment didn't have much morbidity or mortality, then treating 30 patients is not a big deal, but it does have morbidity. And we'll talk about that later too. So they're weighing the number needed to treat, which is the benefit. You're saving lives, but they have to weigh that against the complications and side effects from screening, from biopsy, and from treatment. And like I said, we'll talk about those in a minute. So this is the recommendation that really kind of threw the screening world on edge, because everybody was screening before that, and we knew we were over treating, we knew we were over biopsying, but we didn't have something else. And we started at people presenting with metastatic disease, so this seemed better. But when you got to weigh the benefits and the risks together. So the goal now is to be a lot more selective of who we screen and who we biopsy and who we treat. So whenever there's multiple guidelines, it means nobody really knows what the right answer is. Overall, there definitely needs to be shared decision making. That's the key word again. You need to have discussions about these things and whether it's right for you or not. It's easy to just say screen everyone if you've seen a loved one die from prostate cancer, or if you've seen a lot of people die from prostate cancer like I have. And we learned earlier that 27,000 people are going to die from prostate cancer this year. But if you have a better chance of being harmed by the treatment than being helped, then we shouldn't screen you. And that's something that's difficult to figure out. We don't really have the tools to say yes or no. We have to talk about it and make the decision together. Any more questions about screening? How about you? I can't hear you, I'm sorry.
You were talking about the harm that could be caused if it's treated.
Yeah, we're going to get to that in a second.
Okay.
Yeah, we'll talk about what that is that we're weighing it against. That's in some later slides.
That was also my question. You said harm that could cause by screening.
Right.
What harm can it?
That's right, it's just a blood test, right? It doesn't hurt, it's just a stick in the needle. But the screening leads to biopsies, which leads to treatment. So it's the subsequent.
Not the actual.
No, not from the needle. Some people pass out though, right?
Yeah.
Okay. So how do we diagnose prostate cancer? Prostate cancer usually has no symptoms, like I say now. It's usually found by screening, either with a nodule on exam or by an elevated PSA, which we don't think is inflammation or BPH. Advanced prostate cancer can have symptoms. I mentioned some of them before. You can have local symptoms with problems with urination or blood in the urine, or you can have symptoms from spread to bone. So you can have pain in your hips, your back, or other bones, and you can have weakness and numbness in your legs from cancer pushing on the spinal cord. We don't see that much anymore, but every once in a while you do see someone presenting that way. It's usually found by screening. And this is how we biopsy. So this is an uncomfortable procedure, as you might imagine. There's a probe in the rectum, but it's not very painful. We do it in the clinic. It only takes about 10 minutes. We insert an ultrasound probe into the rectum. And unlike the cartoons here, you can't see cancer on an ultrasound. So we take little snippets of tissue from a grid where prostate cancer usually is, and take about 12 cores usually to try not to miss any. Now, it is possible to have prostate cancer and miss it on a biopsy since you can't see it. That's one of the emerging areas for research, is trying to image prostate cancer. It's been challenging so far. So that is how we do that. And what to expect after a biopsy is some soreness, some blood in the urine is common, some light bleeding from the rectum, and because the prostate makes the fluid that's in the semen, there's blood in the semen often for a few weeks or even a couple of months. There's rare complications. This is what we're talking about. So you can have severe bleeding from a biopsy, especially if you have a bleeding disorder that you didn't know about, or there are blood vessels nearby. It's pretty rare, but you can. And infection, you're going through the rectum to biopsy the prostate, so obviously you can get an infection, and we give antibiotics to prevent it, but it can happen, and it can be severe and life-threatening if it's not treated early. So that's biopsy, and we send the specimens to pathology, and it usually takes less than a week to get it back, and they present the results in the form of a Gleason score. That's the grading of how bad it looks in the microscope, and the patterns that they see are graded between the number of 3 and 5. And the way they present it is as a score, with the first number being the most common pattern, the second number being the second most common pattern. So the lowest grade is a Gleason score of 3 plus 3, which equals 6, and that's considered low-grade disease. And intermediate grade is a Gleason 7. And you see here 4 plus 3 is worse than 3 plus 4, even though the math adds up the same. It means the 4 is more common, and that's a worse pattern. And high grade is anything that's Gleason 8 or higher. And then when we get into staging for cancer, which is what we do to help determine treatment options, we use a T-score to represent the tumor. And a T1 means that we found it by elevated PSA, or sometimes we can find it by accident during surgery for BPH. T2 means we could feel it on exam. T3 means it's extended outside the capsule of the prostate locally. And T4 means it's actually invaded into nearby organs. We use the N number letter to indicate if lymph nodes are involved, and the M to indicate if it's spread beyond the lymph nodes, metastatic spread. We put all these together to give a stage for between 1 and 4, which is common with most cancers. And like I said, those staging is used to help determine treatment. So, anybody have questions about staging before I move on to treatment? No, that's boring, right? So treatment. So there's 4 main categories of treatment. So a lot of men we're not treating right away when they have low-grade disease, lower stage 1, or if the life expectancy is not very long and it's a little bit in its intermediate grade, you can watch it. Now PSA is very good for monitoring cancer. Changes in PSA with known cancer are more reliable than trying to decide whether to biopsy to begin with. So we do PSAs usually every 3 months, and we do a biopsy every few years, and move on to active treatment if either of those worsen. Now, when we're talking about active treatment for localized disease, it's still in the prostate. There's 2 most common techniques: surgery and radiation. And there's a few other techniques, ablative techniques with freezing it or heating it, that don't really have a clear role in prostate cancer right now. But again, if imaging comes along, those partial treatments may be more reasonable, but they're not commonly used. It's surgery or radiation for primary treatment for localized disease. And then there's palliative treatment for the advanced disease. That's actually very effective. It's hormone therapy primarily and chemotherapy, and I'll get into both of these in a second. Surgery I'll start with, since I'm a surgeon. So there's another cartoon of a male pelvis. You can see here's the bladder again and the prostate, and you urinate through the prostate and it comes out the urethra here, and you see it's close to the rectum, and this is the ejaculatory duct we ejaculate from. So if we turn on the side like the guy's laying on his back, and then we look here, this is our bladder right here. There's your prostate that you pee through, and there's the urethra there. These are the veins that are up on top that like to bleed during surgery, and these are the nerves that are responsible for erections. They're not big like that. You can't actually see them. They're in a sheath, but those are the ones we try to preserve during surgery to preserve erections. So when we remove the prostate, just have an open end of the bladder and an open end of the urethra, and then we have to sew that back together. Now, what to expect from surgery is a 1 to 2 day hospital stay. You wear a catheter across that anastomosis from the bladder coming out of your penis for 1 to 2 weeks. You can expect to return to full activity by 6 weeks. There's two most common techniques for removing the prostate. That's the retropubic, where you have an incision from your pubic bone up towards your belly button, about halfway up to your belly button. And then there's the laparoscopic robotic technique, where there's usually 5 or sometimes 6 incisions across your abdomen, and you use the camera to get the prostate out. Now, surgery has risks. So these are some of the risks we're talking about again that you have to weigh against the risks of the benefits from screening. It's a major surgery, so it has all the general risks of the major surgery, like heart attack, stroke, blood clots that can go to your lungs, risk of anesthesia. Death is a risk of any major surgery. There's always the risk of injury to nearby structures in surgery, which includes blood vessels, which can result in severe bleeding, or bowel injury, which can require more procedures as well. Now, these are not expected to occur, but there are side effects that are of treatment that are more common. And this is a little cartoon. The doctor says, "The thieves broke into the pharmacy and stole all the Viagra." And the police officer says, "Sounds like we should be on the lookout for hardened criminals." So you can't have a urology talk without a Viagra joke. So side effects, erectile dysfunction. That's a big deal, big quality of life issue, and urinary incontinence is another issue. We take out the prostate and sew urinary tract back together. Men can leak urine. Now, most patients will need some help getting erections, at least in the first 6 to 12 months. And some will even require more than just pills if they are ever going to get erections again. And most patients do have stress incontinence. That's what incontinence when you cough or sneeze or move, much like a lot of women get as they get older. When the catheter first comes out, almost everybody has it, and it improves over time. But there are some men that will continue to need a pad long term and even may need a surgery to help if there's too much incontinence. Most don't need a pad long term. So surgery has the side effects of ED and urinary incontinence. So guess what side effects radiation has? No, not the same. Almost the same. So they both have erectile dysfunction because they both affect the nerves for erections. But the urinary side effects from radiation are more urinary frequency and urgency. So they're similar but not the same. And radiation also has a potential for bowel problems because the bowel can be in the field that's radiated. And you can get urgency and stool and diarrhea from radiation. Now, when you compare the side effects from surgery and radiation, it's actually a wash. One doesn't have an overall benefit of the other when it comes to quality of life surveys. So when you give everybody how good is your life after this treatment from surgery and radiation, it's about the same. So there are different symptoms, but the quality of life issues, which is what's important when you're talking about these symptoms, end up being the same. And the benefits of radiation is they have very low risks. There's a very small risk of secondary malignancy, meaning that the radiation causes a cancer, but in general you don't have all those operative risks that you have with surgery. And there's two most common ways to deliver radiation to the prostate. There's external beam, where they literally put a beam on, and you go in 5 days a week for 6 to 8 weeks. Fortunately, cancer doesn't grow on the weekends, so you only have to go during the week. And then the seeds, radioactive seeds, can be implanted. That's a one-time procedure. It's a much lower risk procedure than surgery, and the seeds provide the radiation to the prostate over time. And that's obviously nice for the least amount of time out of your life, but it does have the most urinary symptoms afterwards. So men that have a lot of urinary symptoms to begin with aren't really eligible for that treatment. So how do we decide between surgery and radiation once we've decided to do an active treatment? As I mentioned, the quality of life scores are the same afterwards, so that's a wash. That doesn't help you decide. Survival is about the same too. There is a small benefit to surgery, but you have to go out 30 years to see it. So any man with less than 30 years life expectancy is not going to see a survival benefit from surgery. But for younger patients, guys in their 40s that are diagnosed, the surgery may be a better option for them, not only because of that, but because they have less side effects. Younger people do better with surgery. That's just a fact. Where was I? And but ultimately, as long as the patient's eligible for surgery, it's another shared decision-making process. So there's a lot of quality of life and lifestyle considerations that help a man decide which treatment he wants, and often there is a choice. Like I said, the very young, we kind of guide towards surgery, and the older, sicker people will guide towards radiation. But most people are somewhere in the middle and have to make a decision. And most of the time I find it comes down to lifestyle. And then palliative treatment. So people that do present with advanced disease or develop it along the course of treatment, we have treatments for them. So like many cancers, we don't have a cure once prostate cancer becomes metastatic. So the goal of palliative care is to improve the quality of life and to extend the life as much as possible when the cure is not possible. Now, prostate tissue and prostate cancer both use testosterone to grow. So hormone therapy means we block all the testosterone, and the tumors shrink. And it's very effective at doing that, and it can last a long time. And then chemotherapy is usually reserved for people who aren't responding to hormone therapy, or sometimes you can use it up front with metastatic disease. That's kind of some new studies where people are trying that. There may be some benefit there. Any questions about the treatments?
Yeah, irrespective of age or physical strength or whatnot, all other things equal, what is more effective to cure a cancer? The chemo or the surgery?
Well, chemo is not effective for cure at all. You mean radiation or surgery, right?
I'm sorry.
Yeah.
Radiation.
So radiation doesn't cure cancer. Radiation treats cancer. So you're not going to cure it. But the main thing that you're worried about is survival and side effects and risk. So I said anybody up to 30 years, I can't claim that my surgery is going to give you any benefit over radiation for cancer control. So radiation controls cancer, it doesn't cure it. No, but do I see people go to PSA at 0 that for a long time? Yes, sure. But somebody who's 60 or 70, just statistically, is not going to see a 30-year benefit from that. And it's a small benefit at that. So radiation is very effective at controlling cancer. I can't tell you that my surgery is better unless you're in your 40s.
You mentioned the two types of surgery through the abdomen and the other incisions. You didn't mention laser surgery.
Lasers aren't effective for cancer. Laser surgery for the prostate is for voiding symptoms, for BPH.
Okay, I get it.
Any more? Okay, so prognosis. So what is the survival? That's what we care about with cancer. It turns out it's very good across all stages. So the 5-year survival rate is almost 100% across all stages. The 10 years, about 99%, and the 15-year survival is 94%. Now, of course, when you break that out to the higher grades, it's going to be lower. So basically, once you get the metastatic disease, only 28% of those people are going to be alive in 5 years. So metastatic disease is bad. But as far as cancers go, living 5 years with metastatic disease is rare. Most cancers are, you're talking about months, or maybe a few years with metastatic disease. But I've had metastatic prostate cancers that I used to see for years and years and years because our treatments are pretty effective. And of course, everybody's prognosis is much more complex than this. It's based on a lot of different factors. But that's my general slide on prognosis. Any questions on prognosis? So we talked about what the prostate is, what prostate cancer is, how it's diagnosed and treated, and what the prognosis is. And I hope everyone's learned something from this and enjoyed themselves. And of course, we'll ask more questions in a minute, and I can meet with people afterwards if you have questions you want to ask personally. I want to say one more thing. I want to let everyone know about a foundation that's a global charity for men's health issues called Movember Foundation. Every November, they encourage men to participate by growing a mustache. and encourage them to donate, people to donate in their name to help causes like prostate cancer. I participated the last few years, and so I don't want anyone to be surprised if they see me in a couple of months with a fantastic mustache. This is the best the Army would let me grow. Any questions?